Okay, good evening, everyone. Welcome to our webinar series on pediatric epilepsy surgeries. My name is Mary Laughlin, and I am the Northeast Resource Coordinator for the Epilepsy Foundation of Eastern PA. We at the EFPA and our friends at it'sYourEpilepsy.com are so excited to bring you helpful information, insights from epilepsy experts, and genuine experiences from families who have been through surgery journey. We understand and acknowledge that pediatric epilepsy surgery is a very important decision, and to make it often leads to feelings of fear and anxiety. We hope that by providing you with an array of information, you and your family will feel more confident, knowledgeable, and empowered to make informed decisions. If you're a provider, educator, or caregiver, we hope you will feel more knowledgeable and confident in providing guidance and support to others. Before we begin, we want to remind you that your audio and video will be muted for the entire webinar. The webinar is being recorded for future viewing, and you'll have the opportunity to ask questions by typing them into the chat box throughout the webinar. Your questions will be presented to Dr. Kessler at the end of her presentation. The Epilepsy Foundation of Eastern Pennsylvania is your local affiliate of the Epilepsy Foundation of America. We serve 18 counties in the Eastern Pennsylvania and provide education, support, advocacy services to 110,000 individuals in Eastern Pennsylvania alone who are diagnosed with epilepsy and in their communities. We pride ourselves on being trusted guide through the epilepsy journey. We provide many wonderful programs and services. We have seizure recognition and first aid trainings for EMTs, for police, for different companies, for individuals. We have monthly support meetings with their groups. We have advocacy efforts, community awareness events, educational conferences and webinars as this, information and referrals, youth, young adult, and adult services. We have retreats, and you'll see pictures there from our Camp Achieve, which is our week-long sleepaway camp every August, which is a magical time for children between the ages of 8 and 17. So it is my pleasure to welcome and introduce our friend, Clarissa Martinez Rubio at it'sYourEpilepsy.com.
Thank you, Mary. Good evening, everybody. Thank you so much for joining us tonight in this amazing webinar series. It'sYourEpilepsy.com is a specialized website that focuses on drug-resistant epilepsy. If there's information that you're looking for regarding understanding drug-resistant epilepsy, when and where and how to find an epileptologist near you, or to learn more about all of the options that are available other than medications, from the most invasive surgical to all the way to mindfulness and yoga as possible treatments for drug-resistant epilepsy, please do not miss our website. It is live starting today. So again, it'sYourEpilepsy.com. Next slide, please. In the website, you are able to choose how much you would like to learn at once. So if you want to read through our entire chapter, there is one option. But if you want to take things little by little, you can also check out our one-pagers. We have a couple of that have been developed already, but also very important to know is that from every single webinar that we are doing in collaboration with Epilepsy Foundation Eastern Pennsylvania affiliate, we are writing a takeaway message so that after the webinar, we understand that a lot of information can be overwhelming, but we will be sending you a one-pager with the very simple takeaway messages that are the most important key things that you should remember from the webinar. So thank you so much. We are excited to have you join us. And Mary, please take it back.
Thanks, Clarissa. So it's my pleasure to welcome Dr. Sudha Kessler, who'll be talking about when epilepsy medications aren't enough. Thank you.
Thank you very much. My name is Kessler. I am a pediatric epilepsy specialist at the Children's Hospital of Philadelphia, and I thank the EFEPA for inviting me to participate in this webinar series that I'm hoping will be helpful to all of you. These are my disclosures. Go. The goals of this talk are for you to learn what drug-resistant epilepsy is, what epilepsy surgery means, learn what to expect from an epilepsy surgery evaluation, and gain some knowledge that will help you talk with your neurologist about asking for a referral to an epilepsy specialist or epilepsy center for your child. Okay. Unfortunately, I think some of the pieces of this, oh, there we go. So let me start with just talking about what are seizures. I know all of you on this webinar are likely to have experienced them in some way, but what they are biologically, or sort of by definition, are an episode characterized by some transient change in behavior, consciousness awareness, movement, sensation, or autonomic function that's due to hypersynchronous, which means firing all at once, hypersynchronous firing of a network of neurons in the brain. And that can be limited to a very small part of the brain, or it can extend to a very large part, or both sides of the brain. So how is that different than epilepsy? Well, what epilepsy means is a disorder that's characterized by an ongoing tendency to make epileptic seizures. But it's not just the seizures, as you all probably well know. It's also characterized by the biological, cognitive, psychological, and even social consequences of having seizures, and of the changes that they can cause in the way the brain functions. And in fact, epilepsy has many different causes. This is my mental map of what I do all the time. This is my mental map of epilepsy care. So, we begin by making a diagnosis of epilepsy. Some things get called epilepsy that aren't, in fact, once you've done further evaluation. Once we've made a diagnosis, we're interested in discovering what the cause of a particular child's epilepsy is. There can be many different causes. Some of those we can figure out by doing imaging and seeing that there's been some injury to the brain in the past, or a malformation of the brain, for example. Sometimes genetic testing tells us what the cause of the epilepsy is. Understanding the cause can often help us convey to you what the prognosis is for your child. In addition to that, we're also interested in treating the seizures and focusing on treatment that will help a child to stop having seizures, or at least prevent them from happening while they're receiving that treatment. And we should also all remember that part of managing epilepsy is managing everything else that goes with it, whether it's learning difficulties, or the day-to-day stumbling blocks that you might encounter if you have seizures. Today, though, I'm going to be focusing on seizure treatment, especially epilepsy surgery. So what is the goal of treating seizures exactly? Why do we even bother to treat seizures? Well, seizures can interfere with day-to-day life, day-to-day functioning. And so we want to reduce the risk of injury. We want to reduce the need for medical intervention, or hospital visits, or emergency room visits. And we want to help a child with epilepsy, or a child with seizures, have improved day-to-day functioning, thinking, learning, and overall improved quality of life, which is the goal of all of these treatments. So I wanted to talk about, apologies for the animation, I didn't even realize that was there, sorry. So what do we mean when we say drug resistance in epilepsy? Well, this is referring to the failure of two drugs And so why do we say that? There are many drugs for epilepsy. We have more than 20 that we have in common usage, and many more that we know or have used in the past. But the likelihood of finding seizure freedom is not equal with each attempt at medication. And what we've learned over time is that when 2 attempts at treating with appropriately chosen medications for the type of epilepsy that the person has, once those 2 drugs have not worked to get rid of seizures altogether, it's less likely for other drugs to work. And so we call that drug resistance. And here's just an example of, or some more specifics of how that actually breaks down. So we know from some initial studies about 20 years ago that are now quite famous by Drs. Kwan and Dr. Brody in Scotland, that in a large population of people, that after a first medication has failed to lead to seizure freedom, which happens actually in about half of people with epilepsy, a second drug may lead to seizure freedom in a smaller proportion of those. But the proportion that are seizure-free on a third or multiple drugs is only around 4%. And so it gets less likely from there on out. And that's the point at which we start thinking about what other therapies are there. Each seizure by itself doesn't necessarily harm your child, but over a lifetime, uncontrolled seizures can be harmful. Not only can they be disruptive to daily life, they can cause injury, they can affect development, how your child learns, how their memory develops, what their thinking or their cognitive abilities are. They can affect anybody's independence in the long run. And like I said before, they can lead to big disruptions in life, like hospitalizations. They can require lifelong medications or multiple medications, and uncontrolled seizures are also a risk factor for sudden unexpected death in epilepsy. And that's why we want to do our best to get rid of seizures as early as possible. There are really 4 categories of seizure treatments. They come down to medications, surgeries, dietary therapies, and stimulation devices. Each has has many variations and nuances, and today I'm really just going to be focused on surgery. But I just wanted you to know that there are other treatments for seizures specifically. This doesn't include what I think about as the global range of therapies for epilepsy, which includes treatments for comorbidities like anxiety, stress, depression, which are equally important to treat and may require not just medications, but therapy or other interventions, as Clarissa mentioned, for example, mindfulness meditation. But let's talk about what epilepsy surgery means exactly. What is the point of it? Our goal overall is seizure freedom with no new deficits. And so how we do that is to try to identify an area of brain which is making seizures happen. Then we identify whether this area can be safely removed without causing a permanent and unwanted deficit, meaning changes in the way the child functions or is able to function. And then that is followed by surgical removal of the area. So as you can see already, there's an entire process before any surgery is done. And that's what we'll go through in more detail now. So how do we start to figure out where the problem area is? Well, we gather information from many different angles. We are interested in what we call, the technical term is semiology, which just means the description of what happens during the seizure. And so if you ever wonder why you're a neurologist, or when you get admitted to the hospital, everybody wants you to describe what the seizures look like, it's because the description is really helpful to us in understanding what part of the brain is making that seizure, or where in the brain that seizure is spreading to. The description is really critical. So for example, if the first thing that your child does is to have shaking of one arm, it might be that the seizures are starting on the opposite side in the part of the brain we call the motor cortex. Or if your child stops and stares and makes some mouth movements, may have some hand movements, that tells us that the seizures may be coming from a different part of the brain called the temporal lobe. So all those little clues about what your child is doing during a seizure is really helpful to us. And that's why we ask you many times. Another thing that is critical for understanding where seizures are coming from is EEG, or electroencephalography. I bet many of you are already familiar with that because it's one of the ways we also make a diagnosis of epilepsy. What that is a technology to record for us to read the brain waves, which just look like squiggly lines on a page, but tell us a lot about where in the brain might be functioning abnormally and where seizures might be starting. What we can see on an EEG, we'll talk about a little bit in more detail later, but suffice it to say that it's relatively complicated and certainly takes an expert to know how to read. Imaging. One thing we look for on imaging, is there a visible area where the brain is abnormal? For example, has the brain formed abnormally as the brain was forming in utero? Is there, in other words, is there a malformation? Or is there an area where there might be some injury to the brain in the past, maybe from a blood vessel that didn't deliver blood well enough, or from traumatic injury, for example? Another thing that we sometimes use is something called neuropsychological testing. This is a set of tests done with a specialist, a neuropsychologist, who will sit down with a child and conduct one-on-one, either paper and pencil tests or different kinds of questions that they're asked, to really hone in on how that child's brain thinks and how they learn, and what difficulties they might have in certain aspects of learning and cognition compared to the general population of children their age. Because that can also help us understand what part of the brain, whether it's the frontal lobe, the temporal lobe, the parietal lobe, or the occipital lobe, what parts might be malfunctioning and might be involved in the parts of the brain that make seizures. So I hope it's become clear to you already that epilepsy surgery is not done immediately. Evaluation is a process. The first step is that we find out more information about your child's seizures. And the next step is finding out more information. And the next step is finding out more information. And when we've gone through a series of evaluations to get all of the information that we need, a team of providers discusses all of the information and makes a plan. A team led by the epilepsy specialist taking care of your child, but with the input of a radiologist who sees all the nuances in the imaging, by other members of the team who can comment on the neuropsychological testing, on how the child is functioning day to day, and then certainly the team includes the surgeon too. And it's very much a discussion and a collaborative process of decision making that includes you. So after our, for example, at CHOP, we have a weekly meeting to discuss all of our potential epilepsy surgery cases. After that discussion, your epilepsy specialist and epilepsy surgeon will talk with you more about the plan that we're recommending for going forward, either to do more evaluation that's invasive or an actual therapy surgery. And what that recommendation is just depends on the specific circumstances. And I'll talk about each of these further. So taking a step back, let's go into more detail about the phases of evaluation. So the first thing that we often do is EEG monitoring. So this is different than the EEG that you have in the outpatient visits, which is the wires are pasted onto the head just for a little while. We record and then take it all off. For EEG monitoring, this is actually coming into the hospital. Typically, your child will be in the hospital, and one parent or more than one parent can stay with the child, or should stay with the child, to undergo this process that can take sometimes just a couple of days and sometimes can take weeks, depending on how long it takes to actually record seizures. The goal of this procedure is to record seizures. We can get a lot of information from EEG even in between seizures, but there's no substitute for actually recording seizures. The electrodes are placed on the head is wrapped up as you see here, and here's a link to a video to watch a little bit more information about what that process entails. During this hospitalization, your doctors may lower your medications or stop them entirely, so that seizures will happen more quickly. Because of that, usually the child does need to have an IV in place. It usually goes in on the first day and just stays. We don't have to place one every day or poke a child every day. It just stays there. But the reason we have that is because we may be weaning off of medications, the child may have a bigger seizure or a longer seizure than usual and may need a medication given through the IV to stop that seizure. Seizures are really unpredictable and we can't really make them happen. And so the length of stay in the monitoring unit is pretty unpredictable too. Some kids have daily seizures, and so they only need to be in the hospital a day or a couple of days in order for us to record many seizures. But some kids have seizures much less frequently, and so they may need to be there longer. The number of seizures that we need to see on EEG recording also depends on what the EEG shows. It may depend on the seizure type. So there's not sort of one standard for that. So it's definitely when you're planning for this, it's important to talk to your doctor about how long you think you should, plan to stay. And then it's often good to plan on a little extra as well. So what can we see in between seizures? Well, when we're looking at all these brain waves, each line tells us about a different location on the head. And that location can tell us about a whole region of brain underlying that. And we can get little clues as to where seizures might be coming from in between seizures by these little, just fraction of a second abnormalities that we see that are sort of like footprints of seizures or like little sparks. Whereas a seizure itself is not just one fraction of a second event like that. It is a bunch of many seconds of abnormal firing of neurons that create certain patterns on EEG. Another set of evaluations that we do is imaging, and there are different kinds of imaging, and I'll take you through some of the different kinds that we use. One that you have almost certainly heard of is MRI, because again, we also use this in the diagnosis of epilepsy or in the diagnosis of the reasons for epilepsy. When we're evaluating drug-resistant epilepsy, however, we often repeat an MRI, even if your child has had an MRI before, because we may do it with higher resolution technologies, so that we can really see if there are subtle differences in the way the brain was formed. For example, the circle is sort of off, but here is a tiny malformation of the brain that may be causing seizures. Another common difference that we see is scarring of a part of the brain or old injury. For example, the child that had this image had a stroke in part of his brain when he was an infant, and years later that led to epilepsy. And where these abnormalities are really important for us understanding what type of surgical procedure is possible. Another kind of imaging is called MEG, or magnetoencephalography. This is a technology that is sort of like a cross between an EEG and an MEG, and an MRI. It looks for abnormal electrical signals in the brain by detecting the tiny little magnetic signals that come with them. And it puts together all that information on top of an MRI image that is typically obtained on the same day. And so what you end up seeing looks like an MRI, but with some little color blobs on top that tell us where abnormal electrical activity is coming from. And this is another way of looking in a much more high resolution way at abnormal electrical activity in the brain than EEG can tell you. Unfortunately, it can only really look for signals between seizures because this is done in a specialized machine, and so you're only there for an hour and a half. You're not there for days, for example, inside the machine. So we don't usually capture seizures when somebody is getting this test done. But even those little footprints of seizures can be helpful for understanding the whole region that may be involved in making seizures. Another kind of image is called PET scan, positron emission tomography. We all just call it PET. During a PET scan, a tiny amount of radioactive material, which is called a tracer, is injected by IV into the arm. And then an image of the brain shows the places in the brain where that tracer is taken up too much if the area of brain is using a lot of energy, or too little if that area of brain is using less energy than it is expected. And so it can either show sort of hot or cold areas of the brain, and both of which may be abnormalities that tell us something about where seizures might be coming from. Other kinds of testing, one I've mentioned is neuropsychological testing. Something else is called visual field testing, which tells us whether in certain epilepsies that affect the visual pathways, the way that information about what we see is getting into the brain, that can affect how you see. And so sometimes we get that testing. And genetic testing can sometimes tell us about why a child has epilepsy. And that is also important for understanding if surgery is possible and when it might be, what sort of procedures might be recommended. So why is all this testing needed? I've just gone and described a whole bunch of different kinds of studies. Well, it's because putting together, you can't look directly at the brain, and you can't look directly at where seizures are actually coming from in the brain. So it's sort of like putting together a puzzle, piece by piece, to understand where seizures are coming from and what we can do about it. One other test that we sometimes have to do is a different kind of EEG monitoring that records signals directly from the brain. This is often done when our imaging hasn't shown us clearly enough where the abnormalities are. And so this is a way of looking with much greater precision. When you do EEG out here, the signal can get kind of diffused, or can get kind of broad when it goes through all of the fluid and the tissue and the bone. This is a way of looking much, much, much more precisely at where seizures are coming from. There are two types. One is more invasive than the other. The kind that we do most often now in children at many centers is called stereo EEG, or stereotactic EEG. It involves putting needle electrodes into the brain through tiny little holes. So it doesn't really involve opening up the skull. It involves putting needle electrodes in different parts of the brain so that we can record. You'll hear more about this procedure and about surgical procedures in later parts of this webinar series. So let me just give you a few examples of what I mean by therapy surgeries, or what surgeries are actually possible, what we're actually getting at. So one is focal resection. This is when we remove a portion of the brain. It's usually only one side of the brain, and typically within one lobe. The cartoon here shows a temporal lobectomy, meaning the removal of a part of the brain called the temporal lobe, which is one of the most common places in the brain to cause seizures. Sometimes when seizures are coming from multiple places, but all on one side of the brain, or what we call a hemisphere, a procedure is possible called a hemispherotomy, which is a disconnection of one half of the brain from the other healthy side and from the rest of the pathways leading to the body. Some of the most common reasons for hemispherotomy is if one side has been injured by stroke, not just one small part of that side, but extensive areas on that side. And unfortunately, stroke is one relatively common reason for epilepsy in children. Strokes often happen right around the time of birth, for example. Another reason for hemispherotomy is a specific kind of inflammation that can affect a half of the brain. We call that Rasmussen encephalitis. Sometimes kids are born with a whole hemisphere malformed, where the cells didn't get to where they were supposed to go, and the hills and valleys that make up your brain didn't form as they should in order to function properly. That's another common reason for hemispherotomy. Another procedure that we do that actually isn't necessarily a cure for seizures, but can really reduce a specific kind of disabling seizure, which are called atonic seizures, Sometimes those are a combined type. Sometimes people have tonic seizures, sometimes people have atonic seizures, which means a fall, and sometimes those are combined. In this procedure, a highway of pathways that connect one side of the brain to the other is disconnected surgically. And what that does is it prevents the kind of rapid communication between the two hemispheres that lead to these two specific kinds of seizures. So this is just giving you some examples. Each surgery is obviously tailored to the specific child, the specific situation. But I wanted to give you some overview of the kinds of things that are done. So what happens after surgery? Well, how long a child stays in the hospital really depends on the patient and the procedure. You'd be surprised how short the hospital stays are for some children, especially the youngest children. Inpatient rehabilitation is a common part of the hospitalization for epilepsy surgery, but the length also depends on the patient and the procedure. Anti-seizure medications are typically continued. Sometimes they can be changed in the few months after surgery if the side effects of those medications are really substantially affecting the child, for example, if they're very sedated. But typically we try not to make changes immediately after surgery because the brain is still healing, and we want it to heal before we make changes to sort of the environment that it sees. Typically, we can wean off of medications, though, after some period of time. We often continue at least one anti-seizure medication for 2 years, but if a child is still seizure-free at that point, we will often try to wean the child completely off of medication so that they can have a lifetime of seizure freedom without medication. And often that's successful, but sometimes one medication or a reduced number of medications does need to be continued in the long term. And it's a way that epilepsy surgery can work with medications to lead to long-term seizure freedom. So I want you to feel empowered to talk to your neurologist about what treatment options there are besides medications. And sometimes it's as simple as saying, can we talk about treatment options other than medications? And also just to think about going into that visit with what your goals are. For many patients with epilepsy, the goal is seizure freedom. Sometimes the goals can be, I want to be free of this type of seizure that is clearly debilitating and is causing a lot of hospital visits, for example. So think about some of those things. If not seizure freedom, how are seizures affecting your child's life in a way that is most disruptive? If your neurologist is not an epilepsy specialist, you can ask them for a referral. We are all used to asking other types of physicians to see our patients to weigh in on something that they have specific expertise in. I don't think your neurologist will have their feelings hurt. And it's just a way of being proactive about asking for what your child needs. It's okay to ask questions. Please ask questions when you see your epilepsy specialist and the surgeon. I often worry more about families that have very few questions or no questions than I do about families that have lots of questions. Knowledge is power, and it will help you make the best decision possible for your child along with your team. I think it's really useful for families to reach out to other families who have been through this process. Just keep in mind that your child may not be like the other family's child, but the Epilepsy Foundation and other advocacy organizations are a great way to find other families who are dealing with some of the same things. Let me move on. So one of the things that I want you to think about is that when you're wondering whether to move forward with surgery or not, you have to think about the benefits and the risks to your child compared to the risk of a lifetime with epilepsy. So just remember that you're not comparing your child now with seizures to your child immediately after without seizures. You're also thinking about, will getting rid of seizures now set her up in the best way possible for the long, long run. Because we do know that a lifetime of seizures, as I said before, can have effects on a child's ability to learn, on an adult's ability to learn. It can have effects on employment and on independence. So all of those things are important to keep in mind. The take-home points I really want you to leave with, though, are that epilepsy surgery is not a last resort. You don't have to have tried every single other medication to decide to at least do an evaluation. Epilepsy surgery is the one therapy that we have that offers a chance for long-term seizure freedom without medication. Because many surgeries are curative, although some are palliative, meaning they improve seizure frequency. In general, the earlier surgery, the better the outcome in children. And that's because childhood is a developmental process, and having seizures not interfere with that process can lead to better outcomes. It's also because children's brains are more adaptable, or sometimes we use the word plastic. They're more adaptable than brains are when they get older. And so removing a portion of the brain is something that a child can adapt to quite well compared to an adult. Everyone is a candidate for an evaluation. A child ultimately may or may not be a candidate for certain types of surgery, but everyone can have an evaluation. Everyone with drug-resistant epilepsy can have an evaluation. But just keep in mind, evaluation is a process, and don't be afraid to talk to your neurologist. So I will leave with that, and I'm eager to take questions.
Okay, doctor, we have a few questions. Someone's recently learned that corpus callosotomies can also help with infantile spasms based on a recent study from Japan. Can you share more about that possibility?
Mm-hmm. I think it's relatively understudied. So it's hard to know based on a single study what we would conclude about the likelihood of it stopping spasms altogether over the long run. But I do think that spasms probably share some mechanism of the way that they occur with the other kinds of seizures, tonic seizures or atonic seizures that we know can be helped by corpus callosotomy. So it's certainly conceivable that it would help with spasms as well. And it's something that I would explore. Often children with epileptic spasms who continue to have spasms, their epilepsy will evolve into a type that also includes tonic and atonic seizures. Again, certainly sort of makes sense mechanistically that that is a possibility.
Okay, thank you. What is the percentage of seizure freedom versus seizure control with surgery?
A great question. It depends a lot on the type of surgery and the cause of the epilepsy in the first place. So I'll give you some general numbers, but again, this is sort of in a population of people. So one of the most common reasons for epilepsy surgery, although it's more common in adults than in children, is something called temporal lobectomy for scarring of a part of the brain called the hippocampus. In people with temporal lobectomies for hippocampal sclerosis or scarring, the seizure freedom rate in the long run is about 80%. For surgeries that involve other parts of the brain outside of the temporal lobe, the seizure freedom rates range from 50% to about 65%. This is based on years of data that also use techniques that may be different than the ones we use now. And so it is hard to, when I quote that data, it is not necessarily specific for the child that's in front of me that I'm counseling. Certain types, hemispherotomy for certain types of epilepsy, or epilepsy, for example, due to stroke, can have extremely high seizure freedom rates. I know it's not 100%, and you think, okay, well, if I'm going to be doing surgery, I'd really like to be seizure free. But what you're weighing it against is a 2 to 4% chance of seizure freedom with each subsequent medication that you try.
Okay. Are there age restrictions for surgery and stimulation treatment options?
Oh, that's a great question. For surgery, there aren't really age restrictions. Surgery can be done at many different ages. In the very youngest patients, so patients under a year old, there are certain situations where we will do epilepsy surgery in children as young as that, but because they have higher risks for surgical complications, sometimes we wait until the sort of the second half of the first year of life or till they're older. But in emergency circumstances, certainly, or urgent circumstances, surgery can be done at any age. Surgery can also be done at any age. You know, it can be done in older children and teenagers. We certainly do that all the time. It depends on the specific procedure again, but really can be done at any age. Devices, it depends on, there are devices. I wasn't going to get into that in great detail, but the three kinds of devices that we have right now in 2021 for epilepsy that are implantable stimulation devices are the vagus nerve stimulator, VNS, something called the RNS, responsive nerve stimulator, and the deep brain stimulator, or DBS. And the VNS can be done in very young ages, even down to under 2. The RNS is approved for people 18 and up, but we have done it in younger teenagers and older single-digit children. And then the DBS is also approved for 18 and up, and I suspect that with time we will have more experience doing that in younger children as well.
Okay. Now, have you ever come across a child who has generalized seizures from all over that would benefit from surgery such as corpus callosotomy? We're just starting the process. Of our neurologist noted that corpus callosotomy or vagus nerve stimulators are the only ones that our child would be eligible for.
Yes, so I definitely think an evaluation is warranted for 2 reasons. One, sometimes seizures can fake us out, meaning they can look generalized when really underneath they're focal. So we always want to make sure that that conclusion is made after careful evaluation of the EEGs, including recording seizures. Because seizures coming from certain parts of the brain can spread so rapidly that they look generalized. And also, yes, corpus callosotomy is done for seizures with a generalized mechanism and specific kinds of seizures in general, but worth an evaluation.
Okay, does your facility offer radio frequency ablation as an option during EEG process?
During EEG, so I will defer questions about specific techniques to Dr. Kennedy, who is our epilepsy surgeon and who's going to be speaking at the next webinar in this series. I would also just defer those discussions about specific techniques for a specific child to other forums.
Okay. Is surgery for epilepsy likely to eradicate hyperarrhythmia for children with spasms?
It can. It depends on the reason for epilepsy. It depends on the etiology for epilepsy. If the infantile spasms and hypsarrhythmia is due to a focal lesion, meaning an abnormality in one part of the brain, whether that is a malformation or an area of injury, or I've even taken care of a child with a vascular malformation, surgery for that can get rid of the spasms and the hypsarrhythmia.
Okay. Now, what are the risks or complications if my child doesn't have surgery?
That's a great question. The risks of drug-resistant seizures are that you will have a lifetime of seizures, and that can affect not just your day-to-day life, like the disruptions that it causes, and you probably have already experienced and recognized, but we know that kids with drug-resistant epilepsy, for example, tend to have difficulties in the way that their cognition works, or their thinking, their IQ, compared to people who have had epilepsy that is now well controlled. It can certainly have risks for safety. Seizures under certain circumstances, obviously like driving a car or swimming without supervision, that can put you at risk for injury or death from those circumstances. And then we know that uncontrolled seizures are the main risk factor for something called sudden unexpected death in epilepsy. SUDEP is not common in children, but it is certainly a risk in adulthood. And so getting rid of seizures as soon as possible can minimize that risk over time.
Okay, now this is very similar. It says, what are the additional risks for surgery for 1-year-old or younger? Are the risks or complications more than the risks of having infantile spasms for longer, which damage the brain the longer that they are left untreated?
Mm-hmm. Yeah, that's an excellent question. And again, sort of depends on the devil's always in the details and the specifics. And so I would encourage you to ask that question to the epilepsy specialist that you're seeing. But in general, in the right hands, with an experienced surgeon, the risks to a 1-year-old having surgery aren't any greater than an older child having surgery. And I can't speak to the sort of specific risks because it depends very much on what surgery and what sort of cause we might be talking about. But I think maybe the general point is that I agree with you that not doing anything, not seeking further therapy when it's possible, has risk in and of itself to development and cognition.
Okay. And what are your thoughts about alerting the parents of surgery complications that can emerge and the possibility of reoperations?
So I missed the first part of the question. Could you please repeat that, Mary?
Sure. What do you think about alerting the parents of surgery complications that can emerge and the possibility of reoperation?
Oh, sure. We always discuss the possibility that seizures won't go away with a first attempt at epilepsy therapy surgery. Sometimes, depending on the procedure that's done, a further surgery can be helpful to get rid of seizures that haven't been cured by the first surgery. And so, yes, that does happen sometimes. That is possible. One of the reasons that may be is that even with all of the different kinds of evaluation that we do before surgery, it sometimes is quite difficult to tell what the extent of the tissue, the area is that might be leading to seizures. And so, a portion may be removed in the first attempt without having without getting rid of everything.
And as a parent with a child with epilepsy, the word surgery of the brain is very scary. Who can help us with more information and help with this stressful situation?
That's an excellent question. Yes, it is scary. I think the word surgery is scary. And then when you're talking about the brain, I can completely relate to why that would be worrisome. I think that there are many different resources that can help. One is there is a lot of information actually on the Epilepsy Foundation website, epilepsy.com, that I think is a great introduction to the different kinds of treatments for epilepsy. It's definitely something that you want to talk to an epilepsy specialist about, who's taking care of many children who have had epilepsy surgery. I think it's really useful to find other families who have been through this. I know that there's many different ways to do that, whether it's on social media, or one website that I find very helpful is called brainrecoveryproject.org. You can search for that. It's maintained by families that have had children with epilepsy surgery. And a lot of that I think can be demystified. Here at CHOP, part of our epilepsy surgery evaluation also involves a visit with a psychologist. That's not so much for evaluation, but also for preparation of the child for going through this, and preparation of the family. You'll also hear from, in this webinar series, you'll hear from one of our psychologists, and also from Child Life, who are specialists in making hospitalizations less scary, more tolerable for children. And it's very, very, very useful to have a Child Life specialist help your child through this process.
Okay. And how do cortical dysplasia develop, and why would they not show up on an MRI at 3 months, but it would show up on an MRI at 18 months old?
That's an excellent question. Focal cortical dysplasias are malformations of the cortex. The cortex is where the brain cells are, what we call the gray matter. And the white matter is where all the wires that connect the neurons are. It's a malformation of just a portion of the brain. And why those happen, we don't entirely know. There's probably many different possible reasons. What we do know is that in utero, when the brain is first forming, all the neurons, the brain cells, are born around the lakes of fluid that are in the center of our brain. And the neurons travel along a little scaffolding that's set up so that they can get to where they're going and form the layers that they need to form for the structure of the brain to form. If those signals get crossed somehow, whether it's because there was just a temporary glitch in the blood flow to those neurons, or there's genetic signaling that's telling them the wrong thing, or there's some temporary inflammation there, whatever it is, and we don't know the causes really, an area of malformation can form. And so those cells are connected to each other in ways that are not normal, and that can lead to seizures. Not all focal cortical dysplasias are visible on MRI imaging, and that can be for a number of different reasons. The age-related one is that at young ages, it's much harder to see the difference between gray matter and white matter. It's because our brains haven't been fully formed, haven't been fully lined by the insulation that covers the white matter of our brain. And so it can be really, really difficult to see with imaging. Sometimes people can have focal cortical dysplasia that we see because when we take that brain tissue out, you can see the abnormal neurons under the microscope that we never saw on MRI. And that may be because it's such a tiny area, or it just isn't enough, the abnormalities aren't enough to show up sort of in a big way on an MRI.
And I think that's our last question that we've gotten. So thank you, Dr. Kessler. It's been a wonderful presentation. I learned a lot, and I'm sure that we all did. Thank you, everyone who spent their evening with us tonight. Next Tuesday, November 9th, we'll have our next webinar regarding how to choose a neurosurgeon with speakers of Dr. Benjamin Kennedy and Kathleen Gilligan. And after November 9th, we'll have 2 remaining webinar sessions in our series. So please join us for those that are of interest to you. They're all from 5:30 p.m. till 6:30 p.m. with the same Zoom link that you used tonight. You'll be talking to families in the last one, so maybe that will help. And for those that need to speak to someone that's gone through this with their child. That may be very helpful. So thank you again. And it's next Monday, or I'm sorry, next Tuesday. I am so sorry. Next Tuesday, November 9th. So same time, same place. Thank you, Dr. Kessler. Thank you all, and take care and have a good evening.